Maybe we should get started.
Certainly. So it's my pleasure to welcome my colleague at Sunnybrook, who is also my good friend, Dr. Catherine Burt. She completed both a bachelor's and a master's in psychology at Queen's and UofT prior to embarking on her medical training at the University of Toronto. She did her ophthalmology residency here at UofT as well, followed by a glaucoma fellowship at the Kresge Eye Institute, Wayne State University in Detroit, Michigan. She's an associate professor in her department, the winner of numerous teaching awards, and a well-recognized speaker at national and international meetings. Her glaucoma research focuses on new medications, imaging technologies, and surgical outcomes. And now I've just learned trials of location of peripheral iridotomies. And she also conducts phase 3 and 4 drug efficacy trials in partnership with industry. Now, what you may not know is that Dr. Burt is also an avid sailor who races bi-weekly during the sailing season at RCYC. And I've had a chance to see a whole new commanding side of her when I've been on a racing boat with Captain Katie. So welcome, Dr. Burt and your team this morning. We're looking forward to your topics. It's going to be very interesting. Thank you.
If I could just state an update, Dr. Burt is a full professor as of last year. So.
Oh my goodness, I'm looking at the wrong page on the web. Sorry, Katie.
Obviously, something needs to be updated somewhere, but that's quite all right. And I've already invited Amandeep out for sale next summer, so anyone else who'd like to come along, just let me know. I'll break out a fresh cat of nine tails for you all.
Looking forward to it.
So without much more ado, I'd like to welcome everyone to this session on the highs and lows of glaucoma. We have 3 talks from 2 residents and my current fellow, and I think we'll cover a variety of fresh clinical problems that one sees in a glaucoma clinic. So to start with, Shabo, take it away.
Thank you, Dr. Burt. Good morning, everyone. I'm Shabo Lei. I'm a PGY5 resident. I would like to thank Dr. Burt and Dr. Batala for allowing me to present in today's Grand Round. All right, our patient is a 40-year-old male referred to us for glaucoma assessment regarding a unilateral right eye IOP elevation after an LPI for narrow angle. The patient is essentially asymptomatic and he's using Timolol BID for both eyes currently. And his vision is 20/30 in the right and 20/20 in the left. His IOP is elevated in the right eye at 33, and the left side IOP is normal at 17. The slit line exam showed slightly shallowed AC both eyes, but the iris plan is flat. The patent LPI in both eyes. Lenses are clear in both eyes, and gonial exam show that the right angle is narrow with swampy line as the most posteriorly visible structure in the angle in 3 out of 4 quadrants, denoted as letter S on the chart. And the left angle is open with scleral spur visible in 3 out of 4 quadrants. And fundus exam shows asymmetric cupping with the right eye cup disc ratio greater than the left one, which is confirmed by OCT. We can see that the neuroretinal ring thickness is significantly thinner in the right eye compared to the left one. And the RNFL thickness and macular ganglion cell analysis are within normal limit. His visual field is full. And his UBM look like this. I would like to draw the audience attention to the configuration of his iris roots in relation to the ciliary body and trabecular meshwork. Here comes our first polling question today. Should we call this a primary angle closure or primary angle closure glaucoma? Should we call it plateau iris configuration or plateau iris syndrome? What do you think?
Thanks, Shava. Do you want to maybe just move back to the UBM so people can see it while they're voting?
Okay.
And we'll give them a few more seconds here.
Yeah.
You've got a nice split here. I'll show you what you got.
Okay. Okay, it's the response is very diverse, and so that's exactly what we expected. So let's see. So let's first of all, the patient has unilaterally elevated pressure, and then there is significant asymmetric cupping and glaucomatous cupping in the right eye. So so this fit the like the definition of glaucoma. So I would call it primary angle closure glaucoma in the right eye. And then there seems a bit confusing about the terminology of Plateau Iris configuration versus Plateau Iris syndrome. So let's talk about it. Plateau Iris configuration is a term to describe the angle anatomical feature where iris root is inserting anteriorly to the ciliary body, and or the ciliary body is anteriorly displaced, giving rise to this forward arching iris root in close proximity to the trabecular meshwork. And Plateau Iris syndrome is referring to a post-operative status where the plateau iris configuration persists and the patient have a tendency to develop close angle and IOP elevation despite a successful LPI. So the patient have elevated pressure after LPI and glaucomatous disc cupping. So the correct answer is D, primary angle closure glaucoma and Plateau Iris syndrome. So after reaching the diagnosis, we switched the timolol to Combigan and added Chavitin to the right eye. And at follow-up visit, his pressure in the right eye is hovering between 21 to 23. So here's the next question. After reaching a pressure of around 20-ish, what should we do next? Should we just continue the IOP treatment? Or should we add something to treat the anatomy? Answer B is adding pilocarpine. C, argon laser peripheral iridoplasty. Or should we take out the lens? Or should we take out the lens plus a procedure called endocycloplasty, where we photocoagulate the ciliary body itself?
We'll give us a couple more seconds to run here.
Yeah.
There does seem to be one leading choice, so let's end it there.
Okay. It's also pretty diverse, and the argon laser peripheral iridotomy, iridoplasty seems to be the most popular answer. Here, I would like to elaborate all these choices one by one. So the question is really whether we should treat the anatomy or not. I think our opinion should diverge based on how likely you think a permanent trabecular meshwork damage will happen with the ongoing anatomical configuration. So there's a Japanese study show that a positional contact between cornea, between iris and trabecular meshwork alone can cause permanent changes in trabecular meshwork. If you believe the trabecular meshwork damage will inevitably happen, you may want to do something. If you believe that it can happen, but not necessarily the case, then you may want to sit around, treat the IOP, and react to IOP changes when if the TN damage indeed happen in the future. But it often takes much more like mental determination to do nothing, and it's much easier to just do something. So if you want to do something about anatomy, here's your choices. Among all the anatomical modifying methods for plateau iris, pilocarpine is probably the least aggressive one. You can even use lower concentration than standard preparation, just enough to pull the iris away from TM. And it has been shown to open up the angle, make the iris root thinner, but be aware of the complications such as this miosis and periorbital headache, forming of cataract, and the risk of retinal detachment. Argon laser peripheral iridoplasty is a technique proposed by Dr. Witch using large spots, low power, and long duration to photocoagulate the peripheral iris. After the surgery, the iris looked like this. And induce tissue contraction to pull the iris away from TM. And the effectiveness has been showcased in a few small studies, but more recently, study with long-term follow-up shows variable results. A systemic review concluded that there hasn't been enough evidence to advocate ALPI as a treatment of choice for plateau iris. So lens extraction has been treatment of choice for peripheral block angle closure. It works for plateau iris too, but certainly not all angle of plateau iris will open up. I think Dr. Witch has reported a series of plateau iris underwent lens extraction, and a significant proportion, I think about 20% of angle, remain narrow after the surgery. Be aware of refraction surprise because these eyes are often small, and the extreme hyperopic status can give rise to IOL calculation error. And then more recently, endocycloplasty is a newly reported treatment modality for plateau iris in combination with lens extraction. So the idea is to photocoagulate the ciliary body and pulling the iris roots backward and open up the angle. And the study has shown that ECP in combined with lens extraction open up the angle more than the lens extraction alone. A few considerations when making the decision on plateau iris treatment: the severity of iridotrabecular meshwork contact, the height, and the extent. So whether this is a full high rising contact or just touching the posterior tips of the trabecular meshwork. And then consider doing a dilation challenge test and using phenylephrine only to dilate the pupil, and then monitor the patient to see if there's any spike of pressure. That can help us stratify patient into high risk versus low risk group. The more pressure spike there is, the more likely the patient will benefit from anatomical modifying treatment. And then the extent of PAS will limit your treatment option because laser iridoplasty will likely induce some inflammation and make the PAS worse. Other factors include the IOP level and whether there's acute attack after IOP, the severity of glaucoma, lens, age, and refractive status. Go back to our patient. We did do a dilation challenge test, and it's negative. There's no significant pressure spike. And after discussing all the options with the patient, our decision was to continue medical IOP treatment alone. There's a few other collective wisdom on the management of plateau iris. So we may watch and just follow up the limited, if the plateau is quite limited, less than 180 degree, or the contact of ITC is very low, just touching the posterior trabecular meshwork. As I mentioned, consider anatomical intervention if dilation challenge test is failed. And if there's extensive 360-degree plateau iris, or if the IOP is elevated, consider ALPI unless there is a significant PAS. Phaco with or without ECP, when there is slightest cataract, you definitely want to keep a very low threshold for taking out the lens. and consider a trial of pilocarpine before aggressive intervention. And you may surprisingly find it's well tolerated in some patients. So after reviewing all the clinical pearl, so let's quickly do another case just to practice the decision making. So we have a 50-year-old female, plateau iris. We know she has plateau iris despite LPI and angle laser peripheral iridoroplasty. His vision is normal. His pressure without any medication is within normal range, but has been documented with a maximum IOP of 29 in the right eye. It's normal AC depth, patent PI both eye, and the angle is not narrow. The lens has shown some traits of nuclear sclerosis, and the optic disc and RNFL is normal. She doesn't have glaucoma, just plateau iris. We did a challenge test with phenylephrine. After the dilation, its pressure increased from a baseline of 14 to 29 in the right eye. And then we treated in the clinic with Combigan and brought it back to 14. So after going through all the treatment options, and the decision is to proceed with cataract removal and ECP for the right eye. So in summary, plateau iris is a non-pupillary block mechanism for primary angle closure. It's still a pretty evident light zone. There's a lot of suggestion and consideration, but very little like a hardcore recommendation or guideline. The principle is to treat the IOP and then consider anatomical intervention. That's the last slide of my talk. Thank you.
Excellent. Thank you, Chabot. There's a question for you from the audience, for you or for Dr. Burt. This is from Brad. If the angle is still narrow post lens extraction, is this usually due to PAS or anatomical position of the iris angle ciliary body?
Honestly, I think it could be either. Different circumstances. If there's a lot of PAS, you're going to start thinking that this is actually a chronic angle closure, whether primary or secondary to the plateau. But most of the time, the angle will be open enough and a little bit less volatile in terms of pressure control once the lens is out.
There's a related follow-up question from Amrit here about ECP and how you do it. So is it limited to the nasal half of the eye, assuming a temporal corneal incision, or can you somehow treat temporal ciliary body as well?
I treat what I can get my laser probe onto. So it's probably 100 or so degrees from the temporal side to the nasal. Matt, do you do a lot of ECP for this?
Yeah, thanks Chabot, and thanks Katie for this case and for bringing this up. I think awareness of this situation is very helpful for our community. I do ECP usually about 180. If Dr. Varma was here, he would tell you can get 220 or 240 by really stretching. When I do ECP for the IOP benefits, then I will do 360, but that does involve making a nasal incision as well. But generally for a plateau iris situation, I would do the nasal. I have a few other comments if you don't mind, Chabot.
Okay.
Did you still, I just wanted to understand, you were saying the gonio was open post LPI, is that right? And if you could pull up the OCT as well, I'd just like to make
sorry, Matt, we started to get Carol's slides up, and I don't think we can go back to Chabot's.
Oh.
Angle was, there was one quadrant where trabecular meshwork was visible, and the rest was only Schwabe's line. So the right eye was still quite narrow. The left was more open. The OCT, it was technically within normal limits, but the numbers were shading down a little bit on the right side compared to the left in the fully presented case.
Yeah, so I just wanted to revisit the diagnosis even. I mean, there is a large disc asymmetry there as well, at least 0.2, or maybe it was 0.4. And I didn't see any focal glaucomatous loss on either the RNFL or on the GCC. So there is a chance that there's just a asymmetry driven by a difference in disc size. So whether it's, primary angle closure or primary angle closure glaucoma mild, I'm still not sure. Whether that would change what we do, I'm not sure. Another
Given that he
comment.
had pressure spikes, probably not.
Well, and that's pressure spikes for me is primary angle closure, but not necessarily primary angle closure glaucoma from a technical staging perspective. And then the other one is the syndrome. Technically, though I can't say clinically I use this very much. The syndrome, I think, technically is your second case where you have an IOP spike post dilation. In particular, that to my understanding was the technical differentiation between a configuration and a syndrome situation. And something else I just want to point out, I think in general, Shebo made a point that angle closure eyes, it's nice to say, oh, let's just take out the lens and there's some refractive uncertainty. These ones have less refractive uncertainty in my experience than the lens rise or the small eyes. These plateau iris generally have a deeper chamber than your typical angle closure eye and often have a more reasonable axial length. So I'm actually less concerned about the refractive outcomes. There's also been studies looking at whether ECP changes the effective lens position. And I think by and large, the answer is it doesn't very much. So I'm a little bit more reassured, but of course, we're always a little bit hesitant when we're doing cataract surgery, a little bit more for the glaucoma side as opposed for the visual significance of the cataract, and making sure we have an informed discussion with the patient that they're not going to be blown away by their cataract surgery results versus when their friend had it with Dr. Lloyd and was really impressed after they got their cataract taken out.
100% agree with the importance of the discussion and managing expectations. And I agree with your points in general. Can we move on now to Carol and look at a different clinical scenario?
Hi, everyone. My name is Kirill. I'm one of the third-year residents in the program. I'd like to thank you all for being here, and Dr. Bird and Dr. Batella for helping me put together this case. So my case is titled "To Trab or Not to Trab," and like Hamlet, this is a bit of a tragedy. So you're in your office and you have a patient that comes in for a second opinion. She's a 58-year-old. She is already on 4 classes of IOP lowering medications. She's been treated for glaucoma since 2014. At one point, she's gotten some laser peripheral iridotomies. She doesn't have any family history of glaucoma, but she is Caucasian and she has a past medical history of migraine. So she's here understandably worried. She's been offered a trabeculectomy for her left eye for progression. So on examination, her vision is 20/25 in the right, 20/30 in the left. There's no relative afferent pupillary defect. Intraocular pressure seems pretty good at 11 millimeters in both eyes. The anterior segment shows your patent LPIs, and central cornea, I think, is about 505 in the right and 524 in the left. Gonioscopy reveals an open angle. Next, you look at the nerve, and you see that the right eye has a cup to disc ratio of about 0.3, and the left eye has a cup to disc ratio of about 0.7 with a fairly noticeable inferior temporal notch. There's some peripapillary atrophy evident more on the left than the right, and as you notice, pertinent negative is no optic nerve hemorrhage. So next, she shows you test results 3 months apart on her cell phone that she took pictures of from the other office. So let's look at the Humphrey visual field. First initial one, you'll see in both eyes, the left and the right, you're seeing arcuate nerve fibril bundle defects as well as paracentral visual defects. Now, 3 months later, you're seeing pretty much the same picture, perhaps again, nerve fibril bundle defects in the left with paracentral visual defects, and similar in the right, with about very similar values of mean deviation and the visual field index. Next, she showed you her optical coherence tomography. So for the right and the left eye initially, she's showing evidence of superior and inferior thinging in the right, with an average RNFL thickness of 76 microns. And in the left eye, she is showing perhaps only visible in the RNFL clock hour diagram, also some superior and inferior thinning. And then 3 months later, the right eye appears stable, but suddenly the left eye is reading significantly less. She's lost about 8 microns on average, and she's gone from 100 in the inferior quadrant to about 66. So my first poll question to you is there evidence of progression? Yes or no? What do you think?
We'll give him a few seconds here, Kirill.
Mhm. I'll
But
go
it is
back
starting
the
to tilt
slide if you want
one way, so I'll end it here for you.
Okay. Okay. Great. So let's look carefully at the OCT. So when we look, there's the signal strength is about 6 out of 10 in both eyes, and you can see here that suddenly on one of the RNFL clock hours, the reading drops to about 15. Now that's quite below floor. You can also notice that there's a tiny little black kind of lacunae here that's probably severely skewing the readings here. So there's quite a bit of artifact that's possibly causing a change in the RNFL that we're seeing. So you decide to repeat all of the testing in your office. Let's start with the Humphrey visual field. So here the patient, understandably, is very worried. She's very motivated. She's doing very well, very reliable testing. In your office, you get, again, evidence of arcuate neurofibril bundle defects, as well as paracentral visual defects, about minus 6.3 to about minus 6.8 decibels of mean deviation in both eyes. When you do OCT, what you find is about 83 micron thickness of the RNFL in both eyes. You find that actually the inferior quadrant in the left eye, the one that you were concerned about, is still about 100. You still note difference of the inferior superior neurofibril defects in both eyes, and this is consistent with the ganglion cell analysis. So actually, based on the testing in your office, as well as the visual field, both the visual field and the OCT, there's probably she has been stable for the past 3 months. So now, what do you think how would you diagnose this patient? And this is the next poll question. Does she have moderate glaucoma, advanced glaucoma, or does she have non-glaucomatous optic neuropathy?
Well, you tricked him once, Kirill. Let's see if you can do it again. You got a bit of a split here. Let's see.
Okay, great. So let's visit the definitions of what is advanced glaucoma. So there is 2 definitions that we can use. One is the International Classification of Disease, the definition of advanced glaucoma, and the other one is the sort of the HPA definition of glaucoma. So the ICD-10 states that you have glaucomatous optic nerve abnormalities. Yes, we do. Glaucomatous visual field defects in both hemifields. Yes, that is present. And or loss within 5 degrees of fixation in one hemifield. And this is pretty much critical one when it comes to normal tension glaucoma. Similarly, when we look at the HPA, so Huddle-Parison-Anderson criteria for a severe defect, the only criterion that is missed is the mean deviation is less than minus 12 decibels, but everything else really is meeting criteria for advanced glaucoma, largely because of the central visual field defect. So this is actually advanced glaucoma. So next poll question, what would you do now? First option, perform in Humphrey Visual Field 10-2, obtain visual field and OCT records from 2014 onward, or measure IOP fluctuation over 24 hours.
All right, we'll let it run for a couple more seconds here.
Sounds good. Perfect. Okay, great. So actually all of these are good options. So let's review what are some potential things, what is the utility of these in evaluating a patient with normal tension glaucoma. So what is the utility of the Humphrey Visual Field 10-2 in advanced glaucoma? So there's 2 differences. The Humphrey Visual Field Test 24-2, which is most commonly performed screening test, tests about only 12 points within 10 degrees of fixation. So these are the big squares here, whereas the Humphrey visual field 10-2 has 68 points within 10 degrees of fixation. So you're really focusing on this point here. And in normal tension glaucoma, we know that normal tension glaucoma has predilection for central vision. So you get these percentile visual field defects early compared to nerve kind of nasal arcuate visual field defects in high tension glaucoma, as we know classically. And as we know, central vision loss has the highest quality, highest impact on vision-related quality of life. And as I'll show you later, 10-3 also can be a bit more sensitive to tracking progression and potentially response to treatment. Although at this point, it depends on which study you look at. What about circadian IOP variation in normal tension glaucoma? So here I have two pieces of data here to show you that probably this is not as important as it is for high tension glaucoma. So this first table is from a 1991 study, one of the first studies describing normal tension glaucoma patients. Really, the most important part to look at here is magnitude change. So when we look at patients with primary open angle glaucoma or high tension glaucoma, the 24-hour IOP shows a greater variability than the clinic IOP, whereas the same relationship is not seen for normal tension glaucoma. A more recent study from 2012, looking at about 177 patients, looking to see if circadian IOP variation predicts visual field changes in normal tension glaucoma, found no relation at all. So perhaps this is not the most high yield thing you can do. So let's go back to the case. We have a 50, and this is the next poll question. What intervention would you offer this patient? You have a 58-year-old female. She has a central visual field defect. She's on 4 classes of medication for it and has an IOP of 11, and she's stable over the past 3 months. A, observe for an additional 3 months. B, trabeculectomy. C, SLT. And D, minimally invasive glaucoma surgery.
There's a lot of tilt towards one answer. The audience likes observation.
Okay, and that's probably reasonable. So let's talk about the rationale for intervention in advanced glaucoma. So glaucoma is a neurodegenerative disease that is characterized by progressive loss of vision, and all the interventions are aimed at slowing down the rate of progression. So if you catch someone early, you have multiple opportunities for stepwise reduction in progression so that hopefully people do not go blind before they die. Whereas if you find someone in an advanced stage, if you treat them inadequately, then there's a high chance that they will suffer significant consequences for a large portion of their life. So when you encounter someone with advanced disease, you really need to be thinking of aggressive intervention to try and preserve vision-related quality of life. So it helps to understand what is the natural history of normal tension glaucoma. So we know this from the collaborative normal tension glaucoma study, which was a randomized control trial. In that study, 50% of people showed no progression over 5 years, but they showed a fairly wide spectrum of progression. And they found that the risk factor for progression were having a female sex, having migraine, and having optic nerve hemorrhages. And 2 of these are present in our patient. So what is the evidence for trabeculectomy in normal tension glaucoma? Again, from the CNTGS, if you're able to get 30% IOP reduction, you can reduce your risk of progression for 35 to 12%. But to get to this 30% IOP reduction, 43% people require trabeculectomy. Recent studies show, and this is a retrospective review of 131 eyes from Moorfields, show that you can get fairly efficient, fairly robust IOP reduction and very effective control of glaucoma progression in the study. However, as you see here, lots of people are studying with a pressure above 15. So how does this apply to patients with an IOP of less than 15? So understandably, these patients are fairly rare and the literature is a lot more sparse. So on the left is a study from Japan looking at 28 patients with 5-year follow that specifically focuses on rate of change in the visual field. And they find that after trabeculectomy, there's actually a decrease in the slope of the mean deviation change in the 10-2 visual field, but in the 30-2 visual field. However, this study didn't really talk about any potential complications. So an earlier study, again, looking at about 28 patients, looked at the endpoints of achieving 30% IOP reduction and showed that about 50% achieved 30% IOP reduction. That is this line here. However, 30% also at some point during their treatment course develop hypotony, and about 6% develop hypotony maculopathy. So complications of this procedure need to be weighed against the potential benefit that the patient can experience. So complications of trabeculectomy as it relates to normal tension glaucoma are fairly challenging to really fully estimate because of the studies with fairly low sample sizes. But looking at trabeculectomy as a whole as a procedure for treatment of glaucoma, it's possible that now as surgical techniques are getting refined, that the rates of all of the various complications that you can get with trabeculectomy are less than what has been initially reported. The next question is there any role for minimally invasive glaucoma surgery? So this is a table from a study surveying all of the surgeries performed in the United States between 2013 and 2018. We're just going to look at the last line. So we can see for normal tension glaucoma, 30% of patients undergo trabeculectomy, and a lot of patients get eye stents put in. All of the other categories are very small numbers of patients undergo. So one would expect there's quite a bit of retrospective data, at least on eye stent. And when we look, and there's many studies looking at eye stent, and typically in combination with cataract extraction, what you'll get is about a reduction in the IOP of about 10 to 20% and a reduction in medication burden. Most do not achieve 30% IOP reduction, which is the classical endpoint, and perhaps it's not something you need to aim for, but you get a pretty sustained and robust decrease in intraocular pressure, as well as pretty sustained and robust decrease in medication burden. So perhaps for a patient that has 4 medications and is quite motivated right now, perhaps lowering the need to take as many medications is beneficial. So knowing this, what would you offer this patient? You still have the option of trabeculectomy, MIGS, or reassurance and observation.
And we'll just give that a couple more seconds for some more responses. Another split here, Kirill. You've done a good job.
Excellent. All right, great, excellent. So that's all very valid answers to this question. So now I'm just going to throw another question at you here that's basically the same, but now she comes to you next and she has evidence of progression in the left eye. What would you do now? Would you offer trabeculectomy, MIGS, or still reassure and observe? And MIGS is eye stent plus cataract extraction.
We'll let that run for a couple more seconds here. Less of a split. People want to do something this time.
Okay. All right. Excellent. Okay, so as this case demonstrates, making a decision in this situation, in this type of scenario, is very, very difficult. There's not a lot of evidence to guide us, and we're already starting at a very low IOP. So let's just summarize what are some factors that may push us towards surgery and push us towards against surgery. So for surgery, we know that this is advanced disease. We know that fixation is threatened, and that has the highest impact on the quality of life. We know that we could reduce her medication burden. She's already on 4 medications. Will she stay motivated to keep taking them? She also has 2 risk factors that the CNTGS identified as risk factors for progression. She's female. She has a history of migraine. However, against surgery with trabeculectomy, she's fairly young, so she has a higher risk of surgical complications. So starting IOP is low. It's difficult to attain 30% reduction, and there's a risk of hypotony, as I've mentioned as shown previously in retrospective studies. Even if we get 30% IOP reduction, there's still a 12% chance that she'll progress. And of course, as we've seen, she's actually been clinically stable over the past 3 months. So that's pushing us against surgery. So probably, it's okay to observe, but this is not an easy decision to make in this case. And there's not a lot of evidence guiding the decision here. So this end, I would like to thank you all for listening to this presentation and for dutifully answering all of the poll questions that I've posed for you.
Thanks, Carol. That's a fascinating discussion of the various decision points in these difficult cases. Matt, I noticed that you were quite chatty during the presentation. Do you want to contribute verbally as well?
Well, thank you, Kirill. I think you did outline a lot of the issues, and I think based on the available information, I agree with you that it's a little bit of a judgment call regarding what to do, and the stakes are high. I think you also just presented a lot of the classic findings that we deal with and grapple with in glaucoma. I mean, the one point I made in the chat is that I have had over the years many patients sent to me, you know, when the referral says normal tension glaucoma status post LPI, I go back to Chabot's case, and many of those patients are maybe not normal tension. They're actually fluctuating all over the place because they still have times where they have iridotrabecular contact. And that could be in dark situations or basically situations that you're not going to see in the clinic. So keeping in mind that there's other diagnoses other than normal tension. Normal tension is a diagnosis of exclusion. And then the other point, which I think you highlighted nicely, is this concept that IOP lowering does help for normal tension glaucoma, but only if you can get there. So you got to make sure that you can get through all of the complications. And that's why I do think in some of these patients, especially when they're going for cataract surgery anyway, we may consider safer approaches, not because we're trying to achieve that 30% reduction, but we're just trying to get what we can in a safe way in the context of a advanced eye, where if we have a rocky course after, say, a trabeculectomy, then we could actually affect their fixation much quicker than if they would have just waited for the generally slow process to occur.
Yeah, I agree. I tend to want fairly robust evidence of progression before trying to push it down into the single digits. And once you've got there, trying to stop at 5 and not go down to 4 can be technically quite challenging. Is there anything else on the chat line, Amandeep?
Just one question that you guys have addressed it, but for the sake of the video, Ropressa or the Rho kinase inhibitors, would that change management for you guys?
I think I answered that saying that since I can't work with it, it's not available. I haven't any practical experience. Alan says that he got one patient for a corneal indication, which I'd actually like to hear about. But the last I heard, there's no immediate plans by the manufacturer to bring it into the Canadian market, which might be a pity. So in the final 15 minutes or so, we have a final presentation from Dr. Bataya, the glaucoma fellow, with me now until the end of December here from Mexico. Take it away. Unmute yourself.
Morning, everyone. I'm Dr. Bataya. Thanks, Dr. Bird. Thanks, UofT, for allowing me to participate. So we have this case. This is about a 77-year-old female with diabetes mellitus, systemic hypertension, and known drug allergies, and a family history of no family history of glaucoma. She was referred to us because of high intraocular pressure, especially on the right eye, despite 5 classes of medication and 3 classes on the left, and pseudoexfoliation in both eyes. So our nuclear findings were our worst vision in the right eye, some hyperemia, posterior synechia, nucleosclerosis in both eyes, and pseudoexfoliation. She had an open angle, an IOP of 40 in the right eye and 23 on the left, as stated before, with a normal range pachymetry and more large cup to disc radio on the right eye. So we have a 77-year-old patient with a cataract, open angle, very high intraocular pressure on maximal topical treatment, and at least a moderate damage. So here I would like to ask, what would you like to do?
Thanks, Abraham. We'll give it a couple more seconds. Lots of options, but the group is leaning one way, it seems.
SLT, phaco, phaco-mix, Phacotrab, or a glaucoma draining device. So as expected, as expected, more people would go towards the more invasive procedures. So we did a Phacotrab in the right eye, and after why wouldn't you go with the SLT, phaco, or mix? Well, it's because despite they have a good mean intraocular pressure lowering, even in advanced glaucoma, these interventions on their own are just not enough. The patient would likely continue to have some deterioration, some high intraocular pressure, whereas the draining devices or the trabeculectomy are procedures that are much more common in this setting with a lot of medication and very high intraocular pressure. So after 8 weeks of a lot of follow-up, we finally get to a comfortable zone with a patient that was 20/40 visual acuity, 4 millimeters of mercury, and intraocular pressure without drops, and the patient was very happy. At this point, the patient started noticing more the cataract on the left eye. The pressure was still not too bad, but the patient started developing drop intolerance as well. So we did a phacotrabeculectomy on the left eye as well. And here, this table summarizes the follow-up, which seemed routine. On the first day, there was a low bleb. We did some massage, and we got the pressure from high 20s to a much more comfortable teens on the 10 specifically. On day 3, we did an argon laser suture lysis. On the day 7, we did a couple of stitches more as well. And on day 10, we had a more diffuse bleb, a much lower intraocular pressure. And after another argon laser suture lysis, we got a very good pressure in the low teens without medication, without intraocular pressure medication. So up to this point, we allow the patient to have the next visit of follow-up with her local ophthalmologist because she has to do a 2-hour travel to come see us. So we allowed her to go to a local ophthalmologist, and we arranged an appointment for day 23 post-op with us. So on day 23, patient comes in, and she has been seen by someone else at day 17, and she tells us that since 1 week ago, she had vision loss and pain in the left eye. She was prescribed with Diamox and prednisolone every 3 hours, and to this point, the vision fall behind to have movement. She has a very flat bleb, which has no leak, corneal edema, a shallow anterior chamber, a uniformly shallow anterior chamber with a patent iriectomy. There's fibrin in the pupil and in front of the posterior the intraocular lens, and we have no view of the posterior pole. And an intraocular pressure, which was previously 12, now we are in 30 and she's been using Diamox, and it has no changes with a little massage from our part. So here's the next poll question. So we have a patient with uniformly shallow anterior chamber, a patent iriectomy, a very high intraocular pressure, a flat bleb with no leak. Which one of the following is the less likely cause in this case? Misdirection, a pupillary block, suprachoroidal hemorrhage, or a hyperfiltrating bleb?
Lots of different options here, and you're getting a few different responses, so we'll share the results here.
Yes. Okay, well, yeah, we have some of the split. Nobody thought of the suprachoroidal hemorrhage, misdirection, and hyperfiltrating bleb. Let's remember here that we will make up some points next. Thank you. We didn't have a look actually at the posterior pole. We have no view over there. there was just enough fiber in the pupil that we weren't allowed to see through it. So we did a B scan, and here we can see a quiet posterior pole. We see no suprachoroidal hemorrhage. We haven't actually looked, so I was surprised that nobody thought of it. And they do actually thought about a hyperfiltrating bleb. Here are some important points, because let's get to it. We have a very high intraocular pressure, a flat bleb with no leak, and a uniformly shallow anterior chamber. So this is very important, because the flat bleb with no leak will be no compatible with a hyperfiltrating bleb. We have a patent ureectomy that would most of the times rule out pupillary block. And here the B scan let us see that we have no suprachoroidal hemorrhage. So clinically, we are with a patient that has a malignant glaucoma. That's what we went into, AQUEOUS misdirection. So we continued the treatment with antibiotic, keep on prednisolone, keep on the Diamox, and we added atropine. And up to this point, we let the retina team know about this patient. And we'll see why is that as well. So after 48 hours, the vision was not much better, to count in fingers. The bleb was still flat with no leak, uniformly shallow anterior chamber, still the patent ureectomy, and intraocular pressure still very, very high, to 47. So up to this point, and after having the retina team involved and having a discussion with the patient, we went in for a parsplanum vitrectomy, specifically ureterosonular iodectomy. And after parsplanum vitrectomy, we keep on with the very, very strict follow-up, and we can see after the first couple of weeks, and specifically after 1 month, the patient had already a good vision as previous at 20/40, intraocular pressure of 10 on medication, and the anatomic of the anterior segment is all the way back as the eye could manage after at least 4 or 5 days with a very uniformly shallow anterior chamber. So what this case is about is the approach of a shallow anterior chamber with a normal or high intraocular pressure, in this case, very high intraocular pressure. So classically in the literature, you'll find that the most common, or what you have to think about differential diagnosis would be aqueous misdirection, pupillar block, or suprachoroidal hemorrhage. And it's very important that you pay attention to the physical examination and to all the clinical data, because the diagnosis will be made on this approach. So classically, the anterior chamber depth in aqueous misdirection is a uniformly shallow anterior chamber, whereas the pupillary block we might have some degree of anterior chamber depth in the center. Patent ureectomy or iridotomy usually rules out the pupillary block because we're allowing aqueous through it. And well, the posterior pole examination, if we can look at it, we might see that there's no hemorrhage or no other alterations in posterior pole. Though if we cannot see it, we might need to do a B scan. So our patient had aqueous misdirection syndrome. It's a condition referred previously as to malignant glaucoma, which refers to the bad prognosis and not to malignancy or cancer. And we would like you to not use this term. We highly recommend aqueous misdirection because it puts a patient to much less stress. It's a rare condition characterized by elevated intraocular pressure and a uniformly shallow or flat anterior chamber with no pupillar block or other choroid abnormalities. The uniformly shallow would look like this. In either of the periphery and the center, it will be uniformly shallow. Usually they are phakic patients, so it can occur in after every kind of intervention. The pathophysiology is not completely understood, but it's believed that primary mechanism is blockage of the anterior aqueous flow at the level of the ciliary body, combined with an inherent permeability defect of the anterior hyaloid. So that would push the aqueous humor towards the posterior chamber, and this will push the vitreous towards the anterior endothelial corneal tissue. It can occur after any type of surgery. It most often occurs after incisional glaucoma surgery, specifically in eyes with a history of angle closure. How would be the treatment? Well, if you can, if you have time, if you do not have a lens corneal contact, you might start with a medical approach with cycloplegia to pull the contents in the anterior chamber back, aqueous suppressants to lower the pressure, and hyperosmotic agents trying to pull out the aqueous from the features. If you have a good vision to the posterior pole, or at least to the intraocular lens, it would be reasonable to do a laser JAK laser capsulotomy and hyalodotomy to allow passage of the aqueous to the anterior chamber. And if after follow-up of maybe 48 hours, of up to 48 hours, if it hasn't been resolved, you'll have to go for the definite treatment, which is surgery, which is a paraspinal vitrectomy, specifically a hyaluronodular hyalurectomy, which could be accompanied by a phacoemulsification as well, if it's the case. The definite treatment, the hyaluronodular hyalurectomy, consists in creating a unicameral chamber eye so that the gradient pressure is no longer there and the aqueous could flow as normally to the anterior chamber, and we can get back to the normal anatomy of the eye. So in conclusion, it's very important to have a very good look at your patient, perform a very good physical examination, because this is how you rule out one of the other diagnoses. The anterior tests are very important. If you do not have access to a good view to posterior pole, do a B scan, and if you need to do an UVM, go over it. Treat accordingly. If you have time, maybe you want to start with the not so invasive approach and escalate later on, because even though definite treatment will be very fast, it's rarely free of complications. Follow-up is very important. Even if you're going with a medical approach in the first days, make sure you see your patient every 24 to 48 hours, just to make sure how the patient is evolving. And don't be afraid to ask for help. Involve image specialists, the glaucoma specialist, and of course the retina specialist. And that would be the last slide. Thank you.
Thanks, Abraham. That was quite the wild ride for the patient there for a while.
Yes.
Matt commented about using an OVD fill and doing a YAG through the pupil. I agree. Both of those are things that I'll do regularly as well. In this case, we didn't have a view through the pupil. The fibrin is a little atypical for the classic aqueous misdirection. So there may have been an inflammatory component as well, but it certainly limited our choices. I didn't do a fill the first day, and she came back 48 hours later. She still had a preserved anterior chamber over the IOL. So I decided to give her a couple of days on maximum cycloplegics to see what happened. And when she got worse instead of better, we just went straight to paraspinal vitrectomy. I think it's usually Ken Eng who takes them into the OR pretty quickly and deals with the situation. So, but yeah, air helon in the anterior chamber to space things out a little bit and buy you some time is often very helpful.
Yes, thank you, Doctor.
With all the procedures, the massage and the suture lysis, were there any concerns about endophthalmitis when you saw the fibrin, and how did that play out?
Look as bad as that.
Okay.
Fibrin, but the cont was relatively quiet. There was no signs of a hypopion, or the anterior chamber reaction was within the limits I'd expect. So that really was never on our radar.
Yeah, because time is obviously the ultimate judge and jury, but that can be scary when you see that, and it's a knee-jerk to head down that road.
I see fibrin around an implant after a trab, not that rarely, and generally speaking, it melts away. I usually don't even try and cut it with a YAG. It just give it a little time and it'll go away. An infected eye just looks different.
Yeah, thank you.
So glaucoma is often asymmetrical and does funny things, but her first eye got through the surgery with no issues, and then the second eye had the problem.
Yeah.
What if you'd done the first eye and had malignant glaucoma? Would this make you think the risk would be higher in the second eye? How would you deal with that?
Usually, yeah. Aqueous misdirection comes more often than not in a phakic eye. So if I've done a phakic trab, had misdirection, dealt with it, lens extraction, whatever, the second eye, if I have to operate for the glaucoma, I will usually do essentially a prophylactic lens extraction. This lady was in the group who already, the lens had gone at the time of her original surgery. Those are perhaps 20% of the total. That's an off-the-cuff kind of estimate. Those are the ones that you can try, usually, a YAG hyalotomy through the pupil, and even through the iridotomy if you've got access. But that's the majority of the cases that I've seen to handle.
And what would you guesstimate the incidence of malignant glaucoma, or rather aqueous misdirection, excuse me, after TRABs in general? Like, is it 1% or?
Yeah, I don't have a study at my fingertips. Abraham might have looked up something. I would say it's generally given as around sort of 2 to 4%, and I think that's a little high, but you can never ignore it. The other point is that I diagnose aqueous misdirection with a shallow chamber and a pressure that's not compatible with aqueous shutdown or a leak. In other words, a pressure of 5, 6, 8, perfectly normal, low pressures, but not compatible with a flat chamber. There's an active pushing process from behind, and I will call that misdirection and treat it as such. Matt, you're nodding.
Yeah, I agree. It's a misconception that the eye pressure has to be sky high for this condition.
Another way that Our Lady is actually a little bit atypical. And I had one more question about Chabot's first case. That degree of asymmetry between the two eyes seemed unusual to me, even though we know these things are often asymmetrical. Did the patient have some refractive / axial length difference to account for one eye being so closed and the other quite normal? Not that I recall. I don't have the chart in front of me. Abraham's shaking his head, and I think,
oh yeah, I can remember that it wasn't a big difference, and even the refractive error was about the same. It was slightly hyperopic, but that was it.
Thanks, Abraham. We've broken the 8:30 barrier. I'd like to thank my 3 colleagues for their excellent presentations and the hard work they put into the discussion around the clinical case, and to Matt for his contributions this morning as well. John or Amandeep, is there anything else to wrap up with?
No, I don't think so. Again, just a fabulous clinical rounds, really great stuff that we all need to see and be aware of. Thank you very much to all presenters and to Dr. Burt for leading the rounds this morning. And again, apologies and congratulations on full professor. We got to get some websites updated.
A priority item, not.
Great job. Thank you, guys. Have a good day.
Have a good day. Thank you. Thanks, everyone.
Bye.
Thanks very much. Great rounds. Thanks, Katie.